At the outset, I would like to thank Kalila for giving me this opportunity. In fact, when this topic was given to me, I was initially not sure what I would be talking to because it's a very vast topic. But the origin of this topic I had some few days back, where I had one of my old patients. He was just 52 years old. He came with second infarct. I hospitalized him in ICU and his daughter was accompanying. He already had inferior myocardial infarction some 6 years ago, and this was the recurrence, the second event. And the daughter was accompanying the patient, and the younger brother of the patient was informed that your elder brother has got infarct, so you should rush to the hospital. And there are so many coincidences which happen, and it happened that the younger brother who just came to the hospital in ICU as a caretaker relative, he developed myocardial infarction right there. So elder brother being treated for a second myocardial infarction, and the younger brother coming just as a relation at an acute event. Fortunately, both the patients were treated, and the daughter, who was a student of science, she came to me and asked me, "Doctor, what can I do for this? My father had attack 6 years back. He has attack again. And my uncle, who is younger, has a first attack." So I told that your father had missed the bus of secondary prevention, and your uncle has missed the bus for primary prevention. And this is what is the story which we all as practitioners we are facing day in and out. For basic purpose, because we know that most of the cardiac events many times doesn't give us any second chance, it doesn't give any chance. And therefore, we need to focus on prevention. And the very reason I am delighted to talk on this particular topic is that because this topic covers something innovative, something new, though there may be some controversy, there may be some difference of opinion regarding certain aspects of defibrillation. But as a concept, we are so happy that the very first concept was coined in India. So it is a Made in India project. And it is the project, it is the study which has involved thousands of Indian patients as well. And therefore what Dharmesh Bhai was talking, that we are interested in having some research in our own country that has begun long back by Kalila Pharma. So it's indeed my pleasure to be talking on this particular topic. And we all are interested in knowing the risk management, because we know, and the current challenges which we are facing are changing epidemiology. We have so much variation of socio-economic status, the level of education among the patients, and the most important thing, as I mentioned, is the health education. And unless and until we are aware about the changing epidemiology, we cannot health educate the people. Second thing is early detection of risk factor. As I mentioned, that the younger brother who sustained myocardial infarction, if he would have been picked up earlier, we could have avoided the event. And therefore, another is control of risk factor. So how do we propose the solution to these challenges? The first thing is the implementation of guideline, and the answer to that is policy. So we know that it is the cluster of the risk factor. We know it is hypertension, we know it is low HDL, we know it is high LDL, we know it is obesity, and we know it is total cholesterol. So we have more than one factors which is responsible for causing this event, and we need to focus individually on each one of them. So let's start with hypertension. The real scenario which all of us are facing in day in and out is the target control of the blood pressure. Various studies have shown the inadequate control of the pressure in spite of regular visit to doctors. And here is the data which shows that almost 60% of the patients who are treated by doctors, who are regularly visiting doctors, are not maintaining the target blood pressure control. It happens so very frequently that when we propose to the patient that now you need to increase the dose of the medicine, they would always resist. Say, they always have some reason. So on one side, it is the patient's resistance for acceptance of the titration of the dose. And on the other side, what is important is there is a study called pure study. We have, in my practice, because most of my clientele of my patient is middle class and lower middle class, and I have realized that the low cost treatment is the most important factor for treating such conditions. Because a medication which is to be taken lifelong, we need to have a molecule or a drug which is low cost. And the study which has been done, now it showed the low cost medicine are so much underutilized. If you, the study which was done here was a percent of diagnosed patient using selected medication. Those patients who required ACE inhibitor or ARBs, only 19% of them were received. Statin only 14%, beta blockers only 17%, and antiplatelet only 25%. So there is so much of underutilization of the drugs. What are the reasons for that? The cost is of course one, but another reason is that in majority of the patient, we require the combination of all these drugs. Each and every one of them is so very important, and that is not used. So on one hand, the drugs, low-cost drugs are available, the patient acceptance is less, the low-cost drugs available, they are not properly utilized. So that is one part. Second part is, which is affecting we the clinicians, the practitioners, the availability of guidelines. See now recently, most of us have received JNC 8 guidelines for the management of hypertension. But we have a lot of guidelines available to us, the NICE guideline, the ESC guideline, ESC guideline, Indian guideline for hypertension, JNC 7 and JNC 8. Most important thing for all of us now, because JNC 8 has simplified that every patient who has blood pressure more than 149, after lifestyle modification changes, he is a candidate for drug therapy. If the patient's age is more than 60, the cutoff limit is 159. So this is the guideline. Now let us see how the people the world over utilize the guideline. There is a study that is known as Eureka study, and that study was done in Germany and Europe. Now the blue bar which you are seeing is for the German doctors, and the red bar is the European doctors. See, the prevention ESC guideline were utilized by 60% of the physicians and 55% of the European physicians. The ESC and ESL guidelines were used by 45 and only 28% of physicians. They were only used by this many limited number of the physicians. The ATP, JNC 7, other local guidelines and other guidelines. And there were 12 to 13% of the physicians and doctors, they were not following any guidelines. This is a situation and story of Europe and Germany. So my dear friends, you can imagine that though we have availability of the guidelines, we are not properly utilizing the guideline. On one hand, we have drug, there is resistance by acceptance by the patients. There is an inertia on the side of doctors to titrate the dose and to utilize the guideline. So that is another most important factor. So one thing is the acceptance, second is the application of the guidelines, and third and most important thing is compliance. Because I many times realize that in our day-to-day practice, when some patient comes to us and we ask them to increase the number of tablets, I know that there are few cardiac patients who have multiple problems. They are receiving about 12 to 15 to 18 tablets every day. And such patients, they ask me, this is the situation, and in such situation many times we are also confused. So there are certain studies. There is one study which is a compliance to therapy, that is a premier study. Now this study was done following myocardial infarction, and the patient were given only 3 drugs, that is statin, aspirin and beta blockers. And it was analyzed that 66% of the patient continued at the end of 1 month. 12% of the patient discontinued all medication at the end of 1 month. 3% of the patient discontinued 2 medicines and 17% discontinued 1 medicine. And this was all reflected by adverse outcome in the form of mortality at the end of 1 year. So the compliance, all of us know, is a big issue. So the concept of the fixed dose combination came into existence, and most of the fixed dose combinations are accepted earlier by Indians, because most of us know that in the field of diabetology, the combination of sulfonylureas and metformin, which we were using in the Western world, was not accepted. Now they are accepted. The very same thing happened with the polypill concept. Now here there is a study called Empire study, which was done in, which included 2004 patients and done between 2010 and 11, and it utilized the fixed drug combination of aspirin, statin and antihypertensive drug. And what was the conclusion? Those patients who used fixed drug combination, they were compliant 77% versus the usual pair of individual drugs is 23%. So there is nearly threefold increase in the compliance of this group of patients. Another and most important landmark trial for the combination of the polypill, the one which utilized the polycap, because initially there was a resistance, but all of us know Dr. Salim Yusuf, one of the very stalwarts in the field of preventive cardiology. He was the pioneer person along with our Indian doctors, and a very large scale studies were carried out, and it utilized for the control of the hypertension 1 blood pressure drug, 2 blood pressure drug, 3 blood pressure drug versus polycap. Polycap contains atenolol, it contains hydrochlorothiazide, it contains ramipril, it contains simvastatin and aspirin. So 5 drugs are there in polycap, and the study was showing the result that you can see in the this bar diagram. Those patients who were receiving polycap had higher control of systolic as well as diastolic blood pressure. Not only that, the results showed that there was better reduction in heart rate, the LDL levels were better controlled, the platelet aggregation was positively favored, and 85% patients completed the trial in this polycap arm. And therefore, it can be said that the polycap reduces the multiple risk factors. So what are the advantages of this polypill? It offers significant risk reduction. There is improved adherence and compliance, reduced side effect, and of course the cost saving. So which candidate can be benefited? The most important application of this polycap is for those patients who have established event, either ischemic heart disease or a stroke, with or without hypertension, with or without dyslipidemia, or it can be offered in a selected number of patients for primary prevention in patients with hypertension and dyslipidemia. So this is the composition of the polycap, and it has been compared as far as the bioavailability is concerned with an individual tablet. Say it has been compared with baby aspirin, one of the international brands, Zocor, Altes, Tenormin, and in all the comparison, the polycap bioavailability was comparable to individual components, and therefore we can conclude that the challenges and the solutions are CSD and strokes are biggest killers, hypertension and dyslipidemia are major risk factor, they require early recognition and control, and new guidelines recommend polypill for effective control of multiple risk factors. So polycap is effective and well tolerated solution for changing epidemiology. So this is in brief about the utility of the polycap. In other words, in our day-to-day practice, we have been seeing many patients who are not affording. These are the group of patients in a selective group of high-risk individuals in hypertension with dyslipidemia. This application of polycap will be of immense help, And various trials, including TRIPS, have shown significant reduction, as high as 50% reduction in the event rate. So this is a good combination, and I would just like to thank you for giving me this chance. And if there are any questions, any suggestions.